Well, good morning, ladies and gentlemen. I'm very pleased to have the honour of kicking off the conference. And you notice my colleagues have given me the easiest topic of defining what the illness is. Now, let's just see if I can make this work. So, I'm going to cover this area in the next 25 minutes, allowing time for questions at the end. I'm going to try to define what chronic fatigue syndrome is. By doing so, I'm going to review the ICD-10 criteria for the illness and see if they're helpful. The answer will be they're not helpful. I'm going to look at research criteria to see if they help us to try and define this illness in a clinical aspect. Remember, this meeting is about clinicians making the diagnosis and helping patients. And the answer is the research criteria are pretty useless at defining the illness clinically. So we then come to the three clinical criteria at the end to see if they're useful. And two of them actually do have help to us. So the good news is, after some attrition as we skim through ICD-10 and the research criteria, there will be some good news at the end, where there are two particular clinical criteria, the NICE guidelines criteria and the Royal College of Paediatrics and Child Health criteria, that I would commend to you as clinicians as a useful way of starting the process of diagnosis and management of your patients. But nothing is simple, as Albert Einstein said. You've got to keep things simple, but no simpler in life. So there is a bit of a twist in the tail at the end of CFS, where we have the Wesley-White debate of, is there one functional somatic syndrome? Is CFS part of actually a wider one functional somatic syndrome that includes things like IBS, fibromyalgia, and things like that? Or is it the opposite polar extreme, that actually chronic fatigue syndrome is more than one illness? It's actually heterogeneous. So I'm going to just touch on that. And at the end of my talk, I'm going to try and perhaps answer an even more difficult question: what is ME? And I'm going to go back to the original descriptions of ME back in the 1950s to help us, and also make the point, which is, I think, another important clinical point that I'm going to make this morning, and that is that the diagnostic labels we choose to use influence our patients and influence prognosis. If I have time, and I may not, I'm going to make the broader point. Our patients come in and they say to us, well, what is ME? Does it really exist? What is CFS? Does it really exist? The answer is yes, it does exist. And is it physical or mental? And unfortunately, we live in a Cartesian world of dualism. It's either mental or it's physical. The reality, of course, is, anyone with an understanding of neuroscience will know, as we will in this audience, actually it's both physical and mental, and you cannot divide the mind from the body. So let's see and start with the mystery. There's no doubt this is a mysterious illness, as John Scanning has already implied. And we do have a problem with what we call it. Once dismissed as yuppie flu, chronic fatigue is increasingly recognized as a debilitating disease that affects millions. And one of our problems is that labels do count. So yuppie flu, if you were told you would suffer from yuppie flu, how would you feel? So we do have a problem in how we label. And also it's a problem that we have partial responsibility for as doctors and healthcare professionals. From another magazine: if your doctor thinks it's all in your mind, would you like to be told something is all in your mind? Don't assume you're just neurotic. Notice the word just. You may be suffering from one of the new illnesses that doctors are still having difficulty diagnosing. And as you'll see from my talk today, we are still struggling to make the diagnosis of chronic fatigue syndrome and ME. So we are partially responsible for what is going on. So, does the ICD-10 help us? Unfortunately not. There are at least 5 ways, in fact there are probably more than 5, of classifying chronic fatigue syndrome using the ICD-10 criteria. What are they? We start off well. Myalgic encephalomyelitis is in the neurology chapter of ICD-10. Its main title is post-viral fatigue syndrome, and subsumed under that is benign myalgic encephalomyelitis, and helpfully chronic fatigue syndrome, brackets post-viral. Starts off well. So you've got a virally triggered chronic fatigue syndrome. That's your diagnosis. Or is it? What if it's not post-viral? What if the viral illness is not a clear trigger for the illness? Well, you've got alternatives. In the mental health chapter, you've got neurasthenia, which of course was talked about back in the last and previous to last century. Helpfully, it excludes post-viral fatigue syndrome, but includes fatigue syndrome. So if you think someone's got a fatigue syndrome, it's not triggered by a virus, should you be using this diagnosis? If not, one of these 3. If you think that somehow psychological factors have some role to play in your patient's diagnosis or in their illness? Should you use one of these diagnoses, including some beautifully historical, interesting syndromes such as the old effort syndrome, Da Costa syndrome, and whatever neurocirculatory asthenia was in those days. But it gets actually worse than that, because that's 5 possible diagnoses you can use. And the trouble with these diagnoses is you have to somehow guess that psychological factors have an important role to play in their etiology. How on earth can you guess that when someone may be presenting 5 years after the illness started? So difficult to make these diagnostic labels. But actually, if you're more neutral, you don't know whether it's physical or mental, and you want to use a more neutral term, you have got something you can use in ICD-10 in the R chapter, chronic fatigue unspecified, which helpfully includes chronic fatigue syndrome, NOS. You could actually use that if you really don't want to jump off the fence as to whether this is physical or mental, and you are in the dualistic mood. It's confusing, isn't it? And some of my junior staff would suggest that when you get this confused, as I am, over ICD-10, you're always left with the diagnosis, self-diagnosis, of course, of senile dementia. Sorry, senile asthenia. Dementia comes later. So ICD-10 is not helpful, and I would not suggest as clinicians you use ICD-10 criteria. They really need sorting out, and they will be in due course, God willing. What about the research criteria? Well, about every 3 years over the last 20 years, we've been reinventing in committee rooms, no longer full of smoke, of the great and the good, deciding what the illness is. With the CDC starting off in 1988, the Australians, the UK got involved in 1991, London ME criteria, etc., even the Brighton post-vaccinal collaborations got involved now. So are they helpful? Let me just review one. I'm not going to review them all, don't worry. But I'm going to look at the CDC revised criteria of 2003. Let's see what this illness is, according to those research criteria. 6 months, arbitrary timing, you'll note, of persistent relapsing unexplained fatigue. Good start. New onsets, not lifelong, good start. Not the result of ongoing exertion. Not substantial relief by rest, so that's a very nice start, defining the illness. However, the CDC criteria need to have 4, no less than 4 associated symptoms, and these symptoms will be familiar to you, because I know most of you are clinicians who work in this area already. So that's another nice start, except what if you only have 3 associated symptoms? What have you got then? And as you'd imagine, this, as referred from John Scadding, this illness is disabling, so appropriately substantial disability, and later on this morning, we hear about the medical and psychiatric exclusions. Fine, terrific, we're all happy, we've got some criteria we can use. Is there any empirical evidence that there is a discrete CDC-defined chronic fatigue syndrome out there in the population? Answer, none whatsoever. 3 studies, stroke 4, I'll share with you. These are all population studies. The best one, which I'm going to come back to later, is the Swedish study of the Swedish twin registry of adults. Sullivan and more recently Cato have done some lovely work, which is just starting to come out now. The Cato study I'm going to talk about later is in press, or certainly submitted. And this is the biggest study of the concept of CFS ever done in the world at all. And what they've done is looked at these twins. Remember this twin registry? They've taken them from birth and looked all the way through. It's a lovely cohort study. And they've looked to see whether the CDC criteria define a specific delineated illness. And the answer is it doesn't at all. There is no point of rarity from those that have chronic fatigue with less than the 4 symptoms and those that get the 4 symptoms and above. So really there's no evidence on the biggest study that there is that the CDC criteria are useful clinically to make the diagnosis. Similarly in young people, work done by Ann Farmer and colleagues, they were also unable to delineate a point of rarity between CDC, CFS and the rest. And indeed, it's worse, because if you do go for that, and the CDC, that's the Centers for Disease Control in Atlanta, population in both Wichita and now in Georgia, for every patient where you can define arbitrarily, CDC defined CFS, there's between 2 and 8 more patients for every single patient you make that diagnosis on that actually have chronic, disabling, medically unexplained fatigue. So if you use these criteria clinically, you'll be missing out between 2 and 8 times the number of patients who actually also have equally disabling symptoms and illness that you'll be missing out by using these criteria in the clinical sense. So my advice is do not use research criteria. So we come to the clinical criteria. And these are the Canadian criteria. And I've already mentioned the Royal College of Paediatrics and Child Health and NICE, which I think are our answers. But the Canadian criteria are popular in some quarters, so I'm going to review them to see if they're useful to us. Start off well. You've got to have all these 4 symptoms. Fatigue, fine. Which is post-exertional, good. Characteristic feature of this illness. I'm sure all in this audience would agree with that. Sleep dysfunction, agree. At least 90% of our patients have problems with their sleep. And pain, perhaps more arguable. Some don't have pain, some do. But you need this for the Canadian criteria. You've got 4 symptoms already. Now take a deep breath. It gets worse. Because you need 2 of any of this lot. So you're up to 6 symptoms already to make the Canadian criteria. Clinical criteria these are for making this diagnosis. And look at the symptoms. Disorientation, a symptom of this illness. Ataxia. And as a psychiatrist, I would have problems defining emotional overload. So is this really useful? A, you need 6 symptoms already to make the definition. And B, some of these symptoms are very hard to define, and therefore how can we use them clinically? It gets worse again, because not only do you need those 2 symptoms, you need at least one. I don't expect you to read a list, don't worry. This is just to scare you, really. At least one symptom from 2 of the following: an autonomic manifestation, neuroendocrine manifestations, or immune. And look at them. Does irritable bowel syndrome really count towards a diagnosis of this illness? Simon Wesley, in fact, will probably argue it does because of the one functional syndrome. But if you're trying to define a core syndrome, I'm not sure it's helpful to add in another syndrome to make the diagnosis. Or loss of adaptability. What on earth is that? As a psychiatrist, I can't define loss of adaptability to stress. Or new sensitivity to food. Is that really an immune manifestation? And does intolerance to food, which is something that does exist, we know, does it really add to the definition? So you need 8 symptoms to meet the Canadian criteria for a clinical diagnosis of ME/CFS. And the more symptoms you add, what I would suggest is that because these folk, very good folk, who have tried to write these criteria, again in the committee room up in Canada this time, they've been trying to define a core illness. But the more symptoms you add in to define the core illness, the paradoxical effect is that you are actually less chance of defining a core syndrome. Let me show you why. This is work from Simon Wesley. And this is a graph of a psychiatric measure. This is the clinical interview schedule. So the more your score, the more likely you are to have a psychiatric disorder. And the x-axis is the number of symptoms, this time in CDC symptoms, but the same would apply with the Canadian symptoms. And you notice a fairly straight line that the more physical symptoms you have, the more likely you are to meet criteria for psychiatric distress and a psychiatric illness. The cutoff on the CIS for psychiatric morbidity is around 12. So once you go above 4 symptoms, you can see that once you get to 5, 6, 7, 8 symptoms, as Canadian criteria suggest, you are more likely to find someone who's actually got a psychiatric disorder and not CFSME. So I would suggest you do not use the Canadian criteria. So where's the good news? Where's the 7th Cavalry? Well, here we are. NICE, we'll hear later from Richard Baker on the NICE guidelines. And I think we're now going the opposite direction. We start off in the same way as CDC, this time 4 months. Because after all, 5 months is still an illness, so let's make it 4 months, which I think is sensible to reduce from 6 months. Same as CDC, those features, I won't go over them again. Again, the central feature I would suggest of this illness is post-exertional malaise fatigue. So that's in there, it's useful. I think that's the most characteristic feature of this illness. And instead of 4, 1 of these symptoms. The 8 CD symptoms, I'm not showing you again, they're in there. You might argue with some of these symptoms, such as palpitations, is that really part of CFSME? But at least the good news here, we're going for less symptoms to define the syndrome rather than more, that actually paradoxically helps not to define the syndrome. And the normal exclusions that we'll talk about later on. This gets the gold star for me, the RCPCH criteria. And I think these are the best. And they're the best because they make the least assumptions about what this illness is while defining the patients for us. So here we are. Generalized fatigue causing significant impairment. They say 6 months. In fact, for the children, they say 3 months. For which no alternative explanation has been found. Fatigue is likely to be associated, you see, you don't need these symptoms, with other classical symptoms such as the ones that would be familiar to you, and again, classically exacerbated by effort, both mental and physical. and again the normal exclusion. So I would commend these criteria to you as probably the best to use clinically in helping to make a diagnosis on your patients. Right, let's do that twist in the tail, keeping things simple but not more simpler than they actually are, and talk about this. The problem we have clinically, you make a diagnosis of CFS or ME on your patients, and they are more likely to either have or have had other illnesses such as irritable bowel syndrome, fibromyalgia, renal pain disorders, and others. Now, Simon Wesley and Michael Sharp's Lancet paradigm-shifting paper suggested that we're looking at these in the wrong way. And what we should be doing is actually lumping them all together, because there's more in common about people with IBS and fibromyalgia and CFS than there is different. Okay? And therefore, we should be thinking about them together in a wider context, rather than trying to isolate chronic fatigue syndrome separately. Some reactionary diehards like myself disagreed with this and said, no, I think the whole illness, CFS-ME, is actually the opposite. We shouldn't be lumping, we should be splitting. So actually CFS-ME is more than one illness. Let's show you the data to suggest that that is the case. Starting in the 1990s with Ian Hickey in Australia, with a study that Simon and others here have been involved in, looking at clinic patients this time, so we're in secondary tertiary care already. And what they found, even in those days, of just looking at the symptoms and demographics alone, without looking at laboratory abnormalities, you can define at least two separate subgroups. A neurasthenic stroke CFS stroke ME group, if you like, but also a group that have more in common with a somatoform disorder. And every single study who has looked at symptoms and demographics, whether that's Lenny Jason in Chicago, many others, the Swedish group, etc., that they all find heterogeneity. In other words, that when you start to look at symptoms and demographics, you get separate illnesses coming out, however you analyze it. So there's no study that hasn't found this has looked for it. That has looked for it. And what, though, if you go beyond the simple symptoms and demographics, because that doesn't really define pathophysiology. What if you go beyond that and actually look at the endophenotype? The endophenotype, as you know, is that presentation of the illness where you look not just at symptoms, behavior, demographics, but also at the underlying pathophysiology. So the Americans, with the money they've got, this is the CDC, we did a collaboration with them, where they looked at the representative sample in Wichita. Why Wichita? It was in the middle of the United States, and it's highly representative of the whole of the USA. Where they looked, and being lucky in Americans, before the credit crunch, they had the money to look at HPA access on a population-based level. They looked at polysomnography, they looked at autonomic nervous system activity, they looked at everything you can imagine, cytokines a lot. And what did we find? We used a technique called latent class analysis, again looking for groups of patients, clusters of patients. 121 derived from some 75,000 odd people who were screened, in which this is a population-based study where you have to, want to define illness, you've got to go to population levels. Some healthy controls in there as well. And what we found was there are 5 subgroups, 5 split off, that we could split off on the basis of their endophenotype. That's the symptoms mixed in with what's happening at the pathological level. And these were defined by, being America, remember, 2 of them were obese, 2 of these subgroups were obese. And unsurprisingly, they had problems with their sleep. They're stopping breathing, not starting breathing, hope they start breathing, but stopping breathing in the middle of the night. Not so severely with sleep apnea, but small episodes, 5 seconds of stopping breathing, more than you would think is consistent with normal health. Second group had that lot, plus they were stressed. What do I mean by stress? I mean evidence, autonomic nervous system evidence of physiological stress, such as reduced heart rate variability, beat-to-beat variation in the heart, which is thought to be indicative of excessive sympathetic nervous system activity. So the nervous system, the sympathetic nervous system, the autonomic nervous system was involved and abnormal in that group. A group with insomnia and pain, maybe a fibromyalgic type picture or chronic widespread pain picture. And then 2 polysymptomatic groups with lots of symptoms. One group were depressed, and another group, which is probably the smallest group, luckily so because they were the illest, were not only polysymptomatic depressed, they were physiologically distressed, had problems with sleep, severe problems with sleep, as well as being menopausal. Now remember that any statistical technique can give you arbitrary results. So we then try to validate those results against other independent variables. All 5 of those groups were externally validated against demographic and clinical symptoms such as fatigue and concentration problems, etc. We went to the gene level because they had the money to do this. 2 groups you could certainly differentiate on the basis of their gene expression, and 3 groups actually on their SNPs, on their single nucleotide polymorphisms. So some biological evidence that at least some of these subgroups had some biological validity, independently from the analysis that we had. And we've just finished our replication in Georgia. We've done the same thing in Georgia. Sadly, they didn't use exactly the same variables as in Wichita, so we've had to use a bit of creative variable choice to replicate it. What we're finding again is heterogeneity. This work was just published, not published, just finished recently, but not exactly the same as the 5 subgroups as previously I've shown in Wichita. So, do we give up on the diagnosis of CFSME? Since it's heterogeneous, what's the point of making the diagnosis? Well, I would suggest that actually it is still useful to make the diagnosis of CFSME, to lump as far as that. As a final common pathway, the hypothesis, final common pathway for several different disease processes with the same clinical presentation. Okay, rather like kidney failure, presents the same way, has different causes. It has utility, I would suggest, particularly for treatment. But when you're looking at etiology, I suggest we need to split the groups to look at causation. You need to split for treatment at the moment, and it may be in the future. The PACE trial that I lead and run with some colleagues here may show that actually heterogeneity can help us to define which treatment to give our patients, but at the moment it can't. Not being big enough studies to look at that. So certainly for treatment at the moment, as we'll hear later, it's useful to keep it lumpen as a lump of CFSME. Now, nothing is simpler, or rather, everything should be simple, so long as you don't make it too simple, as Einstein said. So was Wesley wrong and White right, as should be the case? Would make a nice change to have it that way. Well, actually, it seems as though both of us were wrong. Both Wesley and White were wrong about this. And this again comes back from that study of Swedish twins that I've mentioned to you already. And they looked at a large number of people, as you know, and what they found, to cut a long story short, is that there were 2 latent, not 1, but 2 latent comorbid traits of folk who had CFS, or indeed chronic widespread pain. One was dominated by mood disorders, which was particularly related to genetic factors. So having depression and anxiety seemed to have some role, determined genetically, in causing or being associated with the syndromes. That's all the syndromes: fibromyalgia, CFS, IBS, recurrent headaches. And the other did not have mood disorders, but had all the others lumping together. So Cato suggested that neither the lumpers or splitters are correct, quoting Simon and I as a reference given. So it may well be that we need to lump and split. Am I confusing you? Well, let's just look at work, again, not our chat, we've just done, looking at this, where we took over 4,000 patients. So I think this is the biggest study of CFSME that's ever been done, looking at etiological factors using the General Practice Research Database, primary care. And we had CFSME patients, post-viral fatigue syndrome patients, matched against IBS and healthy controls. And we found both. What we found was that both the ill groups, IBS and CFS, had more premorbid mood and other functional disorders before the illness, suggesting that the Wesley hypothesis of lumping them together is correct. But at the same time, if you look at the triggers, the particular infections that triggered the illness, as sometimes occurred, not always, were different. So you had a gut infection like salmonella, you got IBS. If you had glandular fever, you got CFS. Suggesting that actually to understand these illnesses, we need to both think about what the predisposing factors are that give our patients CFS, fibromyalgia, IBS, etc., but also what the triggering factors, the final causative factor are. And that may be different and helps us to define what particular illness our patient presents at that time. So last of all, in my last 5 minutes, 5 minutes, John? 4. What is ME? It was first described in 1956 by Sir Donald Aitchison in a Lancet editorial, and he was describing actually a different thing than what I've just been talking about. He was describing epidemics of fatigue with prominent neurological signs and symptoms, something he later regretted doing because he think it confused the picture, and I think he probably did. So let's give you a bit of Melvin Ramsey. And this is the Royal Free epidemic of 1955. This is Ramsey. 74% showed objective evidence of involvement of the central nervous system. I'm not giving you the whole picture, just a flavour. Heavy involvement of the cranial nerves, objective evidence of brainstem and spinal cord involvement. Paralysis occurred, not just the face but other areas, in just under 20%. In other words, this is a different illness. This is not the same. Do you see your patients with facial paralysis? And do you make a diagnosis of CFS if you have a facial paralysis? So I'm suggesting that actually the original definition of ME is different from what I've just been talking about. How did this happen? I'm afraid we're responsible. There it is. 30 years ago this very month, I think it was in this building. It didn't look like this in those days. We did it. We transmogrified, we changed, transposed epidemic ME into endemic ME. So actually we've got a definition of a different illness that we have transposed onto this illness, which I think is where our problem comes from. What message? And they also said at that conference, emphatically, this is an organic, what's that word mean? Incurable neurological disease. Okay? Now, it may be right, it may be wrong, but what message does this give our patients? Now here is the latest edition that you've seen outside of ME Essential. And there are two levels to understand this picture. One, brave attempts of a woman to cope with a severe, disabling, incurable disease. Okay, try and lead a normal life despite of being ill. But what message does that give our patients when we say to them, you have an incurable neurological disease? Is it more useful, a message for our patients, to say that, or to say great exercise therapy is a safe and effective treatment if it's done properly? Because the two statements cannot be, at this moment, joined together. And here's the evidence. Study again from GPRD of the effect of a doctor saying you've got ME to patients compared to saying you've got chronic fatigue syndrome. What we found was that those labelled ME, their illness lasted longer than those labelled having chronic fatigue syndrome. The ME patients had more consultations both in general and specifically for fatigue with their general practitioner. In spite of the fact that before diagnosis, because this was a longitudinal study, there was no difference between CFS and ME in consultation rates or in fatigue consultations, suggesting that diagnostic labels we use have meaning not just for us, but for our patients, particularly when they look on the internet for what ME and CFS means. And we'd have to be very cautious in using these labels without adequate explanation for what they really mean and how we're going to help our patients. So I'm going to conclude, to keep John happy. CFS-ME exists, no doubt in my mind, but it's hard to define. I would commend to you the broad-based definitions rather than one with lots of symptoms. Both heterogeneity and comorbidity should be addressed, both in treatment and when looking at etiology. And it's very important that we are aware of what we mean when we give a diagnosis to our patients. Thank you very much for listening.